Hey, Will,
Hey, what's up?
I've been thinking the U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement. For
Yeah,
sure.
it's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glaucomflecken's really fun and super uplifting guide to American healthcare is out, and it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes.
Okay.
Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's right.
We really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glaucomflecken.com/healthcare. Enjoy.
Knock, knock. Hi.
Hello, everybody. Welcome to Knock Knock Hi with the Glaucomfleckens. I am Dr. Glaucomflecken.
I am Lady Glaucomflecken.
Will and Kristin Flannery. Happy to have you join us for an episode where we're talking critical care.
Yes.
How are you with board games? So we've talked about this. Your extreme lack of competitiveness.
Well, there's two things happening. There's that.
Like your pathologic.
There's no, it's
lack
not that
of-
it's not that I'm not competitive. It's that I'm not competitive about things that have no practical consequence in the real world.
What
Like
is
things that are just for fun, I do not feel competitive.
Oh,
Those are
what-
just fun.
What are something you are competitive about?
Well, I'm competitive with myself a lot about work. I get competitive about work. I get competitive
With yourself? Come on. Give me
Well,
something.
like to I don't know. What's
You've
a
never
goal?
wanted to beat somebody at something? Has that ever crossed your mind? Like, I want to do this
I want
thing.
everyone to do well. I do. That is just I don't feel a need to have winners and losers.
Well,
Let's
it's not
all
that-
be winners.
It's not that you want
Let's
someone
just
else.
all do our best.
It's not that you want someone else not to do well. It's just that you want to do better than
I get
they
it, but
did.
in order to, that just makes them feel bad. It feels bad to lose.
I can confirm to all of our listeners that Kristin is the worst person to play board games with. Because every 30 minutes is every 30 seconds, I should say. It's just what are we doing this for? Existentially,
Yes.
why?
Why am I spending my
Why
life
is this a
sitting
thing
here?
that exists in the universe? I love games. I am a very
If
competitive
you put some
person.
stakes on them, maybe, I don't know. There's just, for me, there needs to be some real world implications of something for it to keep my attention. The other thing is I have ADHD. You can't blame me.
Okay, well, I think this game, Critical Care, the game, is actually probably up both of our alleys.
Yeah,
because
It does have real world implications.
it does have real world implications, kind of. I mean, it's a
it's
game.
like real world learning.
Yeah. But also, it seems like there can be one winner, but you could also just learn a lot, and you love learning.
Yeah, I do love learning.
In the course
and I like
of playing this
collaborating
game.
and cooperating. I like games that are cooperative.
Yes, and this is a cooperative type of game. You could play it lots of different ways, but it's really cool. We interviewed the maker of this game, first of its kind. I've never heard of like a medical themed game like this.
Yeah.
Other than Operation.
Well, right. One that is meant to be somewhat realistic.
Yes. So, Critical Care, the game by Dr. Lakshman Swamy, who is a pulmonary and critical care doctor in Boston. And he does a lot of education in his line of work, with med students and residents. And so it's a very unique perspective. Finished his training at the height of COVID too.
Yeah.
So man, he's been through a lot, and it's it's this game is several years in the making. Talking with him, and it's so impressive. We go through, just talk about some critical care stuff, and I learned a lot.
Yeah.
I know you did too, because I just don't know a lot about critical care in general, and so it was a really fascinating conversation. So definitely check out Critical Care, the game, and I hope you enjoy our conversation with Dr. Swamy. Hey, Kristin.
Yeah.
I know that you love when I talk about the cute little mites.
Mm-hmm.
Yeah, but I thought we could take a break from that. Is it okay with you?
That's fine.
Yeah, because I'd like to focus on the eyelid symptoms and disease that an overgrowth of Demodex causes.
Okay, I like that idea. No mite talk.
So Demodex blepharitis, it often gets misdiagnosed or just missed entirely because a lot of symptoms overlap with other eye conditions.
Okay, so what are the top symptoms that people should look out for?
Usually itching along the eyelid margin, swelling, irritation, redness.
That sounds like it could be allergies or lots of other things,
It
too.
could be a lot of things, but exactly. And the key is if your doctor spots crusties on the margin of the eyelid.
Technical term.
Well, we call them collarettes, but crusties is a good term. That tells you it's Demodex blepharitis right there.
Well, I really like that there's a clear sign to know for sure.
And once you're diagnosed, there's a prescription eye drop treatment available for this disease.
Oh, that is good to know.
To learn about the common symptoms of Demodex blepharitis and more, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Hey, Kristin?
Yeah.
There's this podcast that's every clinician should listen to.
Ooh, what is it?
It's called the Sepsis Spectrum. It's all about sepsis, which is a really important topic.
It sounds like a big deal.
It is. And it's not just like fluff and, your typical CE. It's like gripping narratives.
Ooh, I love a gripping narrative.
Yeah, fascinating to listen to. And so you're having fun listening to it and learning.
Gripping narrative and CE.
Yeah.
You don't hear those two things often
The Sepsis
together.
Spectrum by Sepsis Alliance and critical care educator Nicole Kupchik. You can listen to the Sepsis Spectrum wherever you get your podcasts or watch it on Sepsis Alliance's YouTube channel. To learn about how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. All right, we're here with Dr. Lakshman Swamy. Thank you for joining us.
Oh, it's so exciting to be here. Thank you for having me.
So we used to interact on Twitter back in the day.
R.I.P.
Back when Twitter was a thing that a lot of medical professionals still enjoyed using. So it's good to finally see in person.
You too. Those are certainly the good old days in many ways.
All right. So I'm sitting here with a box in front of me. And as an ophthalmologist, I will say it does strike me a little bit of anxiety into my heart to see critical care, the game. Even just critical care in general makes me a little bit nervous. It reminds me of my time, when I used to actually go to the hospital.
I like that that's why it makes you nervous. It's not that it reminds you of the time you were a patient.
Oh, no.
critical care.
Just, the ICU months that I would do, during my intern year. As an ophthalmologist, we develop a legit allergy to it. Like I get a rash.
Right. I think that's probably like an evolutionary strategy to protect the patient.
When was the last time you saw an ophthalmologist in the ICU?
Oh my gosh. It has been pre-pandemic, many years.
Are we still because I haven't gotten one of these in a while. Are we still consulting for patients with candidemia?
Listen, I try. Okay, I try. You should see the stuff we get consulted for, okay?
I figured I gotta see what the evidence shows, the most recent evidence, because before it was like whenever there's any kind of fungus in the blood on cultures, then it was like, oh, we got to check the eyes. We got to get the eyes checked to see.
Why?
Because it can be a kind of an indolent, not obvious until you actually like look back there and you see little fungal spots in the retina.
It's an easy place to see inside.
I mean, the fungus can go anywhere. For some of us.
Yeah. For an ophthalmologist.
Yeah. How are your fundus exam skills these days?
My eye exam is limited, let's say.
Yeah.
But I do look at the eyes.
Oh, that's all I ask for. That all I ask is that, and you make sure that the patient doesn't come in wearing contact lenses.
Oh, that's a bad one.
That's the big thing.
That's a bad one. Yeah,
Yes.
it is kind of a good. It's to me, it's really optimistic that we would ever call you for something like that, because what it's saying is we're thinking that far ahead.
Yeah.
We're not just worried about this person living, through the next day. We want to make sure.
Sure. Yeah. I think it's
Yeah.
fine. You can always consult ophthalmology for anything. And we come in, we show up wearing our business clothes, carrying a luggage. It's hilarious for everyone
hush goes
involved.
through the unit.
Yeah.
Did you see?
Is that
They're
him? Is that
real.
is that the ophthalmologist? All right. So before we get into what you've been developing here, because I gotta say this game, looking at it's impressive. It is amazing.
Oh, thank you.
So critical care of the game. So we'll talk all about it. But first of all, I have just two questions that relate to some somewhat traumatic experiences that I had as a trainee, like in the ICU. So I'm just curious, because you are like the epitome of critical care. You're teaching, right? You have residents and fellows and all the
epitome
things, right?
is strong. I think that, the interesting thing about critical care is probably similar with ophthalmology. There's so many flavors of it everywhere you go.
Okay.
And I
Gotcha.
really think all of it's important, whether you are taking care of like the sickest people on ECMO and all that, or you're kind of more in a community hospital and taking care of people who just need some life support for a little while.
Right.
No, just some light life
Just a
support.
Little bit of
That sounds
basic life support.
So
there.
weird as a non-medical person, let me tell you.
Well, how long have you been at so your employer, is it Harvard Medical School? Are you like, what's your...
It's an affiliation through the university. So I work for Cambridge, the Cambridge Hospital, Cambridge Health Alliance, right? Which is essentially it's a public system, right? And the hospital has an affiliation with Harvard. So we get Harvard medical students, all of our trainees are Harvard and all that. I am certainly not at, the really big, fancy, high-tech sort of like very elite Harvard institutions. But I do get to say that I have a Harvard affiliation, which is exciting.
There you go. That's good. So where are you in relation to like everyone knows, like, Mass General,
right, yeah,
Brigham and Women's, is that so you're not a part of those hospitals?
No, so there's so much money, so much politics around all this stuff in the city, right? So it's really interesting because there's a number of different hospital systems that all affiliate with Harvard. So the biggest one that people think of is like the MGB system, right? Formerly known as Partners, which is Mass General, Brigham. They have a bunch of other hospitals too. And then there's like the Beth Israel, right? Beth Israel Deaconess, that's another system. And then, Boston Children's, right? I did all my training at Boston City Hospital, which is BU, not Harvard. And now I work for Cambridge Health Alliance, which is affiliated with Harvard as well. So it's kind of it's kind of like a confederacy. What we have in common is a lot of the educational stuff, right? But
Gotcha.
Our sort of salary and everything comes more through the hospitals.
All right, so here are my questions. What are your thoughts about this voice of God ICU system thing, the remote thing?
Yeah.
Is that still a thing? Because that was, I had to deal with that as an intern.
Oh boy. Yeah. It's okay. So there's different ways to use technology in the intensive care unit. And so I got to say this kind of carefully. So I think that there are some of these tools that have really powerful uses, but in like kind of select scenarios. So let me give you an example. We recently, I edit a critical care journal, and we published a paper last year about the use of VR headsets for patients who are about to go to cardiac surgery and will end up in the ICU. So this is like pre-op, right? They're outpatients. They put this on, they see what the ICU experience is going to be like before they go there. Super cool, right? Because you can imagine that it's giving them like a real sense. It's otherwise you don't know what's coming, right? Because most of the time you don't know that you're going to end up in an ICU, but in this case you do. So it was pretty cool. Now that's very different than, and you'll see lots of debate on this on social media, using virtual reality. And I think this is kind of it's going to get there. It's going to get there. Virtual reality for people who are in the ICU to help with getting more mobile, like getting them moving early mobilization. There's like a virtual reality with a bike you can put people on. This is like on a ventilator and all this. So you're like, biking in the south of France. And that has some benefit in getting people to move, right? And then you have sort of like the voice of God, right? And I think that these things get more and more dangerous the sicker the patient is, the less they know what they're expecting here, right? Because then it's I think can actually make you really delirious, really confused, right? We already know how horrible it is to have delirium in the ICU and to really be confused, to think that your nurses and doctors are trying to kill you. It's really sad. It's really scary. And I think we have to be very careful because in this environment, you can trigger that.
Oh,
Yeah.
interesting. Okay. Yeah, that was I was in a community hospital in Chicago, and so there was limited coverage at certain times of night, and so sometimes I would go into a room as an intern, and then the voice would be like,
someone like me is watching.
Exactly. It may have been you. I don't know. Anyway, I just it was like very like jarring. Like, oh my God, what is that? They're seeing everything I'm doing. So that was the first time I ever experienced that. But speaking of the VR headset, I think that would be actually useful for ophthalmologists so that we can know what it's like to be in the ICU. I just a thought.
Oh my gosh.
There's a study to be done around this. So
absolutely,
anyway, that's a good idea.
Puts you more at ease. Yeah.
It's just, Chris, exactly what you said. Like, how is it that for an ICU survivor, that is what you are, right?
Yeah.
You have more anxiety about your training experience.
Dude, I have very limited memories of my time in the ICU. Yeah. It was like I have like flashbulb.
He was dealing with some short-term amnesia. I
had quite a bit of amnesia around the event. But here's the other question I had for you. Have you ever grilled a med student or an intern about Winter's formula?
Oh my gosh.
Oh, is that a thing?
Okay, so let me tell you what. There's two parts to this. The first is there great joy and pleasure in grilling a medical student on arcane date? Of course there is, okay? Do I use that? Do I even like weaponize that? Absolutely. I'm that guy. Okay, let me give you an example. And I hope none of my future interns are watching this. When I'm doing a central line with them, they're doing the whole thing. They've done a great job, right? I'm holding our gloved hands, like I'm holding their hand and like helping them do everything. They're sweating bullets, right? Under the gown, the mask, the heat, the lamp, all this stuff. And everything has gone really well, hopefully. Yeah. And at the very end, they're cutting the suture, right? This is the smallest part of the central line. Like you're putting a little stitch in and tying it off. No matter what, it doesn't matter what they do. Second that their blade or they cut the suture, out of nowhere, the whole time I've been very quiet, very calm with them. Too long. And every time they just go so pale, like all the blood drains out.
It's like, I just killed the patient. That's what they're thinking. Great.
I know, right? So that's the first part is that I this is like this. If you ask me to go back to medical school and say like, why do I want to be a doctor? That's it right there. That's the reason. Okay.
Yeah.
Number one. But let's talk about Winter's formula for a second. I also believe that it is a lot more important to do right by the patient and to deliver great care than it is to obsess about like quizzing each other and internalizing all this stuff. So I do this whole like lecture I give them on acid-based stuff. And at the end I say, and I keep telling them, you don't write this down. Just listen, don't write it down. At the end I say, here's my dot phrase that has all the formulas in it. Now, I want you to actually do the formulas because you won't if you try to do it all from memory. It is important to use these formulas in the right setting. It does not matter if you memorize this. Use the dot phrase, work through the little worksheet in your note, and you will always do the right thing. So I believe in, making it easy. I think medicine should be as easy as possible because it's already so hard. But yeah, of course. I mean, gotta grill them.
And help me also, because I actually don't have as much critical care content using like a critical care medicine like character as I should. Part of that's just because of
it's pretty fantastic, but sure.
So one relationship I feel like I could mine quite a bit is that I feel like there's got to be some dynamic between like you and surgeons, right? I mean,
Oh,
I
yeah.
feel like if there's gonna be some conflict,
Oh my
some pet
gosh.
peeves, some like, oh, I can't. Why are they doing this again to me? That's probably the way to go. So can you clue me in here?
Absolutely. So
Help me out.
it's really interesting because I'll also say that the surgeons are often so reliable, right? Such said, like I love them because you call a surgeon to the ICU, they show up, right?
Yeah,
It's
yeah.
not like my dear beloved medical colleagues who are like, yeah, we'll get there, we'll send. No.
Sure.
You're like, hey, and they come and they're so nice. They're like, I know you don't put your hand on the patient's belly. I know you don't do that. Let me just
So
tell you.
the cardiologist takes his time. The cardiothoracic surgeon, she'll come right in.
Right.
Right.
Trauma
Okay.
surgery. Oh yeah. All the surgeons, they show up right away. They show up right away because they're also like, this person's really sick and they like, what I do might make a difference like very soon. They're generally,
Yeah.
well, they're often nice. And, but the thing is that you're in a community hospital, right? In many community hospitals, the medical intensivist, whoever the intensivist is managing the surgical patients as well. So people who go to the OR and then need an ICU for a little while, it's not even necessarily such a scary, like, someone who has vascular surgery, they need like close monitoring. They need that level of nursing care to just keep watching them. They're doing great. Everything's fine. They don't necessarily even need life support, but they are coming up to be watched. We are co-managing these people with surgery, right? And it is just, that's the place. That's where you got to go. It is such a mess.
Yeah, the co-management. Because I mean, for the surgeon, it's probably just like, I'm going to look at the incision. And that's...
Yeah, but they're also kind of like, but don't do anything without talking to me. But also, you can't reach me because I'm in the OR. So wait on every decision until I come out of the OR 6 hours later. But it's kind of like,
good. I like that.
I can't wait
that's
for you.
What I could. That's what I could use right there. That's perfect.
I know a certain intern who would be caught right in the middle of that.
Exactly. That's great. Well, so let's tell us the origin of this game. Like, what made you want to gamify critical care?
It's funny. It's funny that you mentioned Twitter from the starting because that's actually where it started. There was a resident, I think her name was Jen Darby, surgical resident, and who we were like tweeting. We were talking on Twitter about how rounds in the hospital could be like a game, and we were just kind of like saying things. Fast forward, I think a year or two later, this was before the pandemic, 2018 or something. And then apparently that idea was sitting in my head, and the pandemic was bad. It was really bad for us. And also in like a bizarrely kind of arrogant, like extremely arrogant way, where in that first month in March and April, in the ICU in Boston, we were like watching these surges come across the world. And it's unbelievable to even like say this out loud now, but it felt like the entire weight of dealing with this pandemic was on critical care. Like no one else was involved. This is just critical care, right? Yeah. That was like that flash moment there. And then of course everything, changed. And so the pressure was just really intense. And I was just about to graduate fellowship at Boston University and in critical care. And
at the height of the pandemic?
Yeah.
Like that's when you were in fellowship? Oh, wow.
2020.
Okay.
Yeah.
Gotcha.
So, and it was both, it was great training. But I learned a lot in those last few months, but it was a lot. And the thing is that for some of us, and I mean, this is certainly true for me. I think it was true for a lot of people. The work in the hospital, it was bad. And it was kind of a lot. They actually protected us pretty well. Like we would do stints and like keep rotating and all this, but it was like in my head, like it had soaked all the way through to my core. All I was thinking about all day, all night, all the time was COVID. Right. And how society was going to fall apart and all this. Like it was like very doomsday in my head at that time. And it was kind of confirmed every time I went to the hospital. It was really, really bad. But it was getting out of hand. And I was unwinding. I was like really, truly falling apart and breaking, and all of my sort of coping mechanisms were really kind of coming apart at the seams. They were just not enough, right? Running, whatever, all this stuff. And then my wife, like, she had this like conversation with this like flashbulb memory you're saying, right? Like where it was almost like she slapped me in the face. She's done that before. That wasn't what she did this time. That was when we were sleep training. That's when I got slapped in the face. But
Hey, wake up.
no,
Your
it
turn.
was I have to go to him. I have to go to my baby. Like,
Oh.
but we're supposed to wait for the timer. No.
Oh gosh.
Oh man. No,
Here's
so-
the timer.
Yeah.
Yeah.
Yeah, right.
So she was kind of like, this isn't okay. I'm like raising these 3 young kids in this pandemic alone, and you're kind of like making it a lot worse. She used more stronger words than that. And it snapped me out of it. And I don't know why, but like I saw them sitting and doing like arts and crafts stuff as kids do, especially, in March and April 2020. And something clicked. I remembered that. And the next thing I knew, I was just like sitting here, and I didn't know what I was doing. I just started writing things down and making it. And could have been anything. Could have been like a screenplay or whatever, but it turned out to be I was making a board game. I don't know why.
Yeah.
I started making a board game. And that's kind of where it started. And then it really took off when I realized what you said in the starting. It says a lot that you have so much anxiety thinking about what it was like being a trainee in the unit, right?
Yeah.
And so in the starting, this was just a pet project for me, but it turned into so many other things. And one of those things was, imagine if you'd been able to play through this once before going to the unit the first time. They don't teach you any of this stuff in medical school. They don't teach you, like I've had students ask the simplest things, like which one of the numbers on the monitor is the oxygen and which one's the heart rate, right? Like they just don't, this isn't the kind of practical stuff that you get until you show up.
Those are the questions you're like kind of afraid to ask because it makes you feel like you're an idiot, like you should already know this stuff.
Right. That sums up the entire problem of medical education. That you can't ask, right? Like
yeah. Exactly.
So that was a big part of addressing. It was like I want people to not be so anxious about it because critical care it's not just important. Like there's a reason we do it. We love it, right? It's amazing to be with people when they're at the extreme, to be at the extreme of like vulnerability and to help them. And there's a part of that for patients and families too, because, so much of my time is spent talking to patients and families. And every time I'm working from like below the ground up, right? People have really so little understanding. I'm sure you know what it's like when you try and talk to people about their eyeballs. Like, I mean, come on, none of us even know what's in there.
Yeah, right. Yeah.
Squishy, gooey stuff.
And I absolutely would have loved to play this game even during my first shift, although I don't know how the patients would feel about me like rolling a dice. rolling dice outside their room. But yeah, let's take a quick break. We'll come back and dive into some of this stuff here. All right, we're back with Lakshman. Let's talk about more about some of the details of the critical care, the game. So first of all, who's it for?
Oh, this is such a good question. It's for you.
It's for me?
It's for you.
It's for me.
For ophthalmologists.
It's we
designed it entirely just for ophthalmologists to feel more comfortable with critical care. So
I love it. I love it.
No, we made it, first and foremost, it's for the general public. I've played this with, in my local town, with, like high school students, right? I think that kids don't know much about medicine. What do you know about it? You're like, I can be a doctor, I can be a nurse, right? And that's the extent of it. It's not, I can be a doctor that does this thing or that. It's like surgeon or not surgeon, kind of, right? There's so much more. But, it was really important to us to say there's so much more in medicine than doctors and nurses. And we put all that in the game. So, I would love to hear that someone out there is playing this game in high school and they pull out the respiratory therapist card and they win the game with it. Oh my gosh, what is like, who knows what a respiratory therapist is?
Right. Yeah.
Right. Like,
I didn't think about it that way. And it's like, it just to get exposure to like, what are these roles in healthcare and what do they do? And I think that's great. That's
we tried
really
to bake it all in there. We've got it. Of course, we have like all the, bunch of doctors and nurses and all that stuff, a bunch of like therapists, like, OT, PT, SLP. We have like music therapy. We've got a chaplain, environmental services. We tried to get
That's awesome. Well, I noticed it does come also with a glossary of terms. Because there's a lot of terms and things that you encounter in the ICU. So I thought I could have Kristin just randomly select
awesome.
one, and then quiz me. Let's go.
Okay.
Oh,
All right.
yes.
Let's go.
Okay.
Let's see what I got.
HFNC.
Next, please. Pass.
It's high flow nasal cannula.
Oh, I know what high flow nasal cannula is. It's just a nasal. You just crank it up. What? How? 10 liters per minute?
Oh,
You can go higher with the nasal
come
cannula.
on. Yeah.
How high can you go with the high flow
How
nasal
high do you
cannula?
want to go?
This says up to 80. Up to
80?
80 liters of oxygen
And then
via the nose.
And then you got to go to BiPAP. Right?
Hey, that's what's in here next.
BiPAP.
That's right.
He's ready.
I've seen the pit. Come on.
Okay.
Jeez, come on. Don't sell me short here. Let's go. All right. Give me something else.
Okay. I'm just looking randomly.
Yeah.
And I landed on devoted family.
Oh. Oh, how does that factor into the game? Where does that come into the game? Devoted family.
Because so I started with diagnoses and like the medical stuff, right? The complications you can get, then the treatments you use, or the ventilator, all the meds and all that stuff. And it quickly became apparent that there is no ICU without the people. And like that is the whole point. And there's a few parts of the people. One is the people you work with. That's the staff, all the staff's in there. But the other part is the patients and families. So all of the patients have we had writers work with us to create backstories. It's like super representative. We wanted people to see themselves in the game.
Cool.
So that's the patients. And then the family, I mean, anyone who's spent any amount of time, practicing in any capacity in the ICU knows that the families, you see families at their best and at their worst. Sometimes the worst is that they're not there, right? So we try to put, the game tries to be very authentic. When there's a devoted family that shows up, that's like all together, they're there, like unified. It's a magical,
thing, right?
beautiful thing. You also see very often the opposite, where there's discord, right? Where people are fighting. They're fighting in the room, like literally throwing punches sometimes and all this. And it's a lot, right? We didn't want to shy away from that. We put all of that in there, right? So the family is a huge part of the game, and it comes out in the gameplay as well. Yeah, because you can win the game by curing a patient, sort of their like medical problems.
I was going to ask, what's the goal? How do you win the game?
So I have one of the boards here. I can kind of show you. Okay, so this is like the board, and then a patient would go here. The diagnosis that they come in, like sepsis or whatever, goes here. Then over here, you can see this is like brain, heart, lung, blood, and then inflammation. We had to make things a little abstract. And this is like their supposed to be their chart, right? And this is like as they get sicker and sicker. And then this is the lightning bolts are like the level of crisis, because it's sort of, you can have a lot of this or not a lot of this and you can still code, right? So when this reaches the top, you code. There's like a mini game that's really hard to win because it's not TV. And then you can,
I've won that one.
Yeah, she won that one once.
You have won that one. You have won that one. But then the whole other side here, this purple side, is a little track, and it starts down here. And this is the goals of care track. And so as you kind of play certain kinds of cards, a lot of the cards that have to do with alleviating suffering or bringing the family to the bedside and having like the high touch care, that goes up and up and up. And so you can also equal win by bringing someone to hospice, right? By easing the passage, because that's a huge part of what we do too.
Yeah, that's a reality sometimes, for sure.
That's so cool. Okay, let's pick another one.
Okay. I'm just noticing, since I'm on the D's, it's very close to the C's. I'm noticing there's no co-survivor in here. So, maybe round 2.
Round 2.
Just keep that in mind.
Yes, absolutely.
Okay. Let's see here. Some of these are too easy for you. I know you'll know them. Trying to find a good one.
I appreciate the confidence you have.
Inhaled. Oh, this backfired because I don't know how to say this. Epoprostenol. You said close.
Inhaled epoprostenol. It's a medication. And
they breathe it in.
You breathe it in. It's probably some kind of, sounds like a steroid.
Like he's on rounds right now, right?
Yeah.
It feels like that.
Sounds like a steroid of some kind. Nope, not a steroid. It's nitric oxide to dilate the vessels.
There you go. It
Boom.
works. It's a vasodilating therapy. Yeah.
But I don't think it is
I cheated.
nitric
I looked.
oxide.
It's
I
not
looked.
nitric oxide. Yeah.
It says
it's l-
or nitric oxide.
or nitric.
Such
Okay.
as.
All right. So this
Yeah.
is a medication. I'd never heard of this medication. Epoprostenol. Okay.
Yep.
All right. Great.
This is like we use this stuff for pulmonary hypertension and all that.
Oh, gotcha.
What is, and this is, the severe ARDS type stuff. What you're seeing though is that we used all the real words, right?
Yeah.
We didn't try to, and the point of that is that, as you know, there's power in language, right?
Yeah.
There's a power dynamic that's always present in the hospital between the doctors and the patients, where the doctors know all the stuff and throw all the words around, and the patients are like, what's happening to my loved
Right.
one? So this is our little attempt to say, like, that shouldn't exist in that way. It's we all go into family meetings saying, I'm not going to use jargon, but
You
it
forget what
happens.
jargon is because it's so basic to you that it feels like it's basic to everyone.
Exactly. So this is our attempt to kind of give people a little bit of a guidebook so that they can learn some of the jargon, because otherwise, you get access to your notes. It's going to say in there HFNC.
Right.
And what is
Yeah,
this?
what does that mean?
Or
Yeah.
if your residents or fellows are talking to an ophthalmologist who came in, and it's like they're not going to use HNFC because clearly, or HFNC because I didn't know what that was. So learning how to really explain things like you're 5 years old or an ophthalmologist in the hospital.
Yeah.
I love it.
Equal levels.
I think
there.
it's very
listen,
smart. It's very smart.
I've got, you can't get away with this.
D-
There's no specialty in all of healthcare that is worse with their jargon.
Yeah. It's true.
None of us can understand. I
Okay,
have to
that's
put
fair
it into
enough.
like Google Translate
true.
to understand what your notes say.
Is ophthalmology a language
absolutely true.
listed in Google Translate now?
It
No,
really,
it should be.
it really is. Yeah, we're bad at it.
It's a
We have a lot
problem.
of acronyms. We throw a lot of P's and H's into our words for really no reason.
The acronyms don't even correlate with English words. It's Latin.
Yeah, I mean, it's Glaucomflecken's it's an ophthalmology term, so it's it's a problem we have. All right, go ahead.
Okay.
Give me another one.
Plasmapheresis.
Oh, plasmapheresis is when you take the blood out of the body, you remove things from it in the plasma, and then you put the blood back in.
What things do you remove?
You can remove almost anything. You can remove heavy metals. You can remove potassium. I think.
A little more dialysis, I think.
Oh,
There you
that's
go.
dialysis. Plasma. What's in the plasma? Oh, you can remove antibodies.
There you go.
What else is in your plasma? The plasm. You can just remove all the plasm in there.
Bad humors.
The bad
Yeah.
humors. Absolutely. What else can you plasmapherese? What?
Let's give us the full definition. Let's hear it.
Yeah.
It
what do you
is.
got?
Which, again, like you got to think like a 5-year-old. What the heck is plasma? Right? You left
Yeah.
that part out. Removing the liquid part of the blood,
Okay.
along with any antibodies in it, can help treat a variety of inflammatory conditions. This plasma is replaced with a fluid, usually albumin.
Albumin. I forgot about the albumin.
I'm going to get that's in italics. So I'm going to guess that's over here in the A's.
You got it.
Yeah, see, I was a good student. I know how glossary works.
I love it.
You have no idea how long it took us to write that.
Oh, it's great though.
Yeah.
Do you have any eyeball things that came up in the making
I
of this?
really should have. I have to say, because I was making this game starting in 2020.
Yeah.
Twitter was like, that was like, still happening. And I remember I was talking to Vince, my co-designer. We were like, is there any way we can get the critical care ophthalmologist in here? Like we really wanted to, and we're like, we just can't. We just can't make it work.
There's really not. There's not a whole lot of overlap between our specialties.
Well, what would happen if here's what I know about critical care ophthalmology. You're not supposed to leave the contacts in.
Yeah, that's
So
like
something
90% of it.
something bad can happen there.
Well, if somebody often, patients will come in, they're already sedated or unconscious.
Uh-huh.
And so you might not know if
Right.
they were. If
But
they
like
were
if
wearing
they leave
contacts.
their contacts in, there's a, what is it? It starts with a P. Pseudomonas? Is it Pseudomonas?
Oh.
That's one of the terrible hospital things that
Yeah.
can be growing.
So,
Yes,
you could have that happen.
Yeah.
The other thing, and I
this is good. You've
just
learned.
am embarrassed to say that I had to ask
This is great.
his doctors whether they had, closed and lubricated his eyeballs
Oh, yeah.
every day.
Yeah,
I was like, I'm so sorry to ask you this. I just know
He's
it's my job as his voice right now.
she did. She
you
had
were
this
standing here next to me.
Yes. He would make me ask this. So I did. I was very embarrassed, but I did it.
I love it.
Well, I mean, both of the things you said, you cannot talk about, and this is like a big part of the game too, but you can't talk about critical care without talking about critical care nurses, right? And all of this stuff. When I was like, oh, of course, the contacts, I have no idea. That's
Yeah.
the nurses do
Yeah.
everything to take care of a
Right.
patient like that, right? Like
Yeah,
I am completely useless without critical care nurses, right? And honestly, that's like where so much of the patient, like hands-on caring for the body, preventing all this horrible stuff from happening is through that. So
Yeah.
One thing I learned during COVID, and maybe it's in this game as well, is the concept of proning patients.
oh yeah, that's
I
in the
didn't
game.
Yeah, I didn't even know that was a thing. So can you explain that?
Yeah.
I'm actually just kind of curious. Like, what does that do exactly?
So, it's this goes back to sort of to the way we don't really learn that much about the human body, right? In school, elementary school, high
I'm
school.
sorry, what? Oh, okay. I
Yeah.
thought you meant as
No.
in med school.
Eventually we do. Yes.
And I think one of the things interesting is that I don't know how, but I somehow, like, because I learned everything like from textbooks in medical school, there's a sense that things are static, like that they're always just a certain way, and that mundane things like the orientation of the body in space could matter, right? I think it's pretty amazing that you can swallow upside down and stuff like that, right?
Yeah.
So you would think, like, I don't know why, but I at least always had this idea that like stuff just is like the body is like in its encapsulated self just works. Doesn't matter, turn upside down, left, right, whatever. It's always the same. That's not true. It's not, it's like obviously not true, right? Like physics matter even within the
Right.
body. So one of the things that is when you are supine, right? Holding the bowl of soup, right? This is how I remembered it. Like
Oh, nice.
lying
Oh,
down
that's
face
good.
up, right? When you're lying
Yes.
down face up. The weight is pushing down, right? And so you are going to have some effects over time where things that are on the bottom are different than things that are on the top. Okay?
Right.
And we see this like with different kinds of sleep apnea type stuff too, right? With the airway collapsing and all that stuff. But in this case, what we see is that the lungs are not, when you take a breath, right? The lungs are not inflating perfectly, fully, equally all the time. It's different based on how you're positioned. It's different if you're awake or asleep. All these things make it like different. This is a really long way of saying this. I'm sorry. But basically,
Okay. No, this is good.
the back of the lungs, right? Which if you're lying down is sort of the bottom, right?
Yeah.
They can collapse more, right? So everything else is on top of it. They're kind of pushing against more to open up, pushing. Like there's not as much space for them to open up and all that. So what happens is that if you leave someone in a hospital bed for a real long time, like days and days on end, and they're just like that all the time, that you don't you're not making use of all that lung as much as you could. So by flipping people upside down, which sounds kind of ridiculous in a way, and proning them, you're
Not
inverting.
by their toes. I just need to
exactly.
clarify.
Yeah.
You're turning them over is
Yeah.
what you're doing.
Yeah.
Well, so go ahead, and then I have a comment about this.
Well, like
but
if you're sleeping on your stomach, basically that's what we're doing,
Yeah.
right? And that takes a lot to do to someone passively to make sure, especially when they've got like tubes and stuff in. This is one of the cool things about seeing like a whole team work with like respiratory therapists, nurses, all these people working together, like efficiently and safely flips them. And then what you see often is that when you have something like ARDS, like when you have like a really bad lung disease problem going on, that all that injury in the lung, you're like kind of like, oh, there's actually like there's more lung that we weren't using as well as we could.
Yeah.
And you see like big improvements then. So,
That's so cool.
what I'm envisioning, do we turn patients like rotisserie chickens?
That's exactly what I was thinking too.
they make beds that do that now.
I imagine they do, like, because that's got like it's kind of like put you in like a little cage and just kind of turn you over.
Get everything moving.
It's amazing.
We just take like the Dick's Hall Pike beds and just
that's right. Just go around and around.
No.
That's fascinating.
Yeah.
That's really cool.
I mean, it makes sense. It's like you said, it's so obvious, like in retrospect, but for some reason we never we don't learn it that way, so we don't continue to think of it that way.
Right.
I say we, I mean you.
All right, give me another one. Give me another one.
Okay, one more. Oh boy. Severe acidosis.
Severe acidosis is like an acid-based disorders. You get like too much for like, a lot of different reasons why you could have an acidosis. There's respiratory acidosis. There's a metabolic acidosis, and it just basically how much acid or lack of base you have in your body.
Okay, why is that a problem?
Because it will damage tissue if you're not at the right pH.
In what way?
Your physiologic pH. What do you mean in what way? In what way?
What kind of damage and which tissues?
It causes cellular damage. It will make it to where your organs don't function well. And then you have to do plasmapheresis.
and proning.
Dialysis.
And dialysis. And maybe even a little proning. I don't know. You have to call the nephrologist in, which I'm sure the nephrologist is somewhere in this game.
Oh yeah.
So and that is my explanation of acidosis.
Okay. Well, wow. The glossary definition is a precise balance of the acids in the body. In other words, the pH is managed by the lungs for respiratory acidosis and
kidneys.
the kidneys for metabolic acidosis. Too much acid reduces the blood pressure, weakens the heartbeat, and limits oxygen transfer in the lungs.
Basically what I said. I don't know how clear I could be.
Pretty much exact, actually. You did the thing where you use the word in its own definition really well.
Yeah, exactly.
So, I'm really good at that. So where's the nephrologist come in?
So the what we wanted to do was try to show that when you call a specialist into the ICU, which you have this experience, right? It's a big deal. It's a big deal that someone comes to help. Right. That's the way that we really wanted to show this, is that you're calling someone for help. They are coming to help you.
Phone a friend.
Phone a friend. Exactly. And it's not just doctors. That was the important part. This is where like the occupational therapists and physical therapists come in here and all that. But the nephrologist comes in, and one of the major things, I have to be really careful what I say. My father-in-law is a nephrologist. So one of the things that nephrologists really care about is the acid level in the body, right? And like just like we were reading, this is what they help with. This is what dialysis can help with. And so the way that it works in the game, because one of the important things is that everything in the game that has like this thematic thing, it's not random. It has like an interaction in the system, right? Yeah. So the little inflammation tokens, these like little wooden, as those build up, that means that the acid level in the body is building, or the inflammation is building, or whatever, right? And the nephrologist has the ability to kind of help get those off in some way, to use that ability, to help in those ways. So same with the cardiologist, pulmonologist. They all have different ways of doing stuff to affect that.
Well, I am looking at the stack of specialist cards in this game, and I see a couple that caught my eye. One is the ultrasound guru. Gotta have one of those. Yeah. An official training program called Guruship of ultrasound.
Yeah, it's a Guruship.
And also a Zentensivist. I like that.
These two were like a little bit of a stretch, but we really, first of all, since we made the game, we got to put whatever we wanted in it.
That's right.
Oh yeah, it's a game.
And there's a lot of sort of our philosophy, our belief system about the ICU that's in here. This intensivist like really captures that. The old sort of way of thinking about the ICU is that we do everything to everyone all the time. If you come into the unit, you're getting every tube put in you that we can put in right away. This is just like what happens, right?
That's how you save lives. Yes.
Right. But now we are realizing that like there's a lot of harm that can happen from overdoing things. So this intensivist is an example of like sort of, don't just do something, stand there, right? Like watch the patient, really be high touch instead of high tech.
I noticed you have names for all of these.
These are all real people.
These are all real people.
Yeah, these are all people that like influenced me, usually like during the pandemic in some way.
Oh,
often
how cool.
Like, a bunch of them are like Twitter friends. So
I'm just not seeing an ophthalmologist named Dr. Glaucomflecken here. That's all
we
I'm
need
saying.
A mini expansion that's entirely focused
on ophthalmology.
On ophthalmology.
Too much to
There will be
ask.
two
I don't
cards.
think it's too much to ask. Well, this is fantastic. I can't wait to really dive into this and play this. And so
I love the idea behind it too, right? That you're like trying to give regular people a sense of many things, right? Like what happens in an ICU, but also, like what it is, how doctors think a little bit, right? Like what you're looking for and what these things that you'll see are, and just with all the misinformation that's out there right now among the general public about bodies and medicine, like I think something like this that meets people in a different way than a lecture or a lesson, you know, like I think these kinds of creative ways of getting information out there are really valuable in this moment in history. So like, I love it.
Yeah. Like no way in hell would I sit and listen to like an ICU lecture, but I would absolutely play this game.
And part of the idea also was one of the most fulfilling parts of it has been, and it's also very like hospital medicine. It's not just ICU, right? Anyone who practices in acute care has this, I think many of us have this feeling. If we have a friend or a partner who isn't in medicine, isn't in healthcare, they don't know what we do. They really don't know what we do, right? Yeah. And playing this game is a way. I remember when someone was playing it a little while ago. One of my residents was playing with their family, and they're kind of like 20 minutes into the game, and her parents was like, "Wait, do you know all this?" She's like, "Yeah, that's
what do you think you paid for?"
Exactly.
So it's a really nice way to share that, because otherwise it's really hard to talk about it. I had a lot of trouble during the pandemic talking about the bad stuff I was seeing, even with my wife, right? So this is kind of like creates a little bit of a bridge to do that.
Yeah, I love that.
Well, congratulations on this, and I hope people will check it out. Where can they find this game?
Oh, yeah. It's
Critical Care, the game.
Yeah, Critical Care. You just Google Critical Care, the game, criticalcarethegame.com, and criticalcaregame.com. And I should know my own website. I'm so bad at this stuff.
You're good.
And Crit Care Game on social media. And it's, we have the Kickstarter, which thank you for supporting it. We did a Kickstarter back in like 2021 something. A bunch of people paid for games to be donated to like academic institutions, to libraries and stuff. We still have a couple left. So if you have like a training program or a library or something,
that's a great idea.
Reach out to us. We're happy to like send a donation copy. The game is available for sale through our website. And before that, like after that, from my garage. So we'll try to get it out to you. It's super fun. I hope you really like get a chance to dig into it. Oh, yeah. I have to say, thank you so much to Sarah Merwin. She helped write that whole glossary. She's like a patient demystifying expert. And it really was, I couldn't have done it without the whole team.
Oh, that's nice.
Yeah. I was just sitting there reading through the terms, and they're very well written and explained. And honestly, it's almost like you have a whole like critical care fellowship in a box kind of thing. But it's like, but you don't have to be a fellow to understand it, which is
and the glossary's
cool.
online. You can just go and read it.
Yeah,
anyone can access it and read it. So,
well, Lakshman, thank you so much for joining us. This was, about time we did this.
Yes, long overdue.
And so I'd love to anytime have you come on just to teach me about critical care.
Thank you.
Something that's never going to help me in my professional career at any time, but it is fascinating stuff. So thanks again.
Thank you so much. Thanks for having me.
Critical care, the game. I wonder what other parts of the healthcare system that would benefit from a game. Insurance? Health insurance.
I don't know if that'd be a very fun game. Aren't we already all playing a game?
We're already playing a game there.
Yeah.
Anyway, if you guys have any ideas of what else you want to see gamified in the healthcare system, maybe we could find someone that would be willing to take it on and make it.
Yeah.
Ophthalmology, the game?
Snooze fest.
You can email us, knockknockhi@human-content.com. Hang out with us and our Human Content Podcast family on Instagram and TikTok over at Human Content Pods. Check out all the podcasts that we have to offer. And thanks to all the great listeners leaving feedback and reviews. If you subscribe and comment on your favorite podcasting app, we can give you a shout out. Like on our YouTube channel, at Glaucomfleckens, by the way. At New Friends on YouTube said, I love how fast Kristin came back with, not all poop is brown. I remember you saying that.
I do.
Yeah.
Yeah. It was when we were talking about Code Brown.
Oh, gosh.
And I said that banana bag should be about urine. And you said not all urine is yellow. And I said, well, not all poop is brown.
It's a very true statement. Full video episodes are up on our YouTube channel at Glaucomfleckens. Check that out. Tons of cool perks over on Patreon. Bonus episodes or react to medical shows and movies. We just recently did a hangout with some of our patrons.
That's right.
That was always fun, just answering questions and just chatting about things happening in the world. Early ad-free episode access as well, interactive Q&A live stream events, much more. Patreon.com/Glaucomflecken. Shout out to the Jonathans as usual. Patrick Lucia C, Edward K, Mr. Grandetti, Caitlin C, Brianna L, Mary H, Keith G, Parker, Muhammad L, Kaylee A, David H, Gary M, Eric B, Marlene S, Scott M, Kelsey M, Brian S, Patrick S, Sean M, Jessica M, Hawkeye MD, Bubbly Salt, and
Johnny D.
Patreon roulette time. Random shout out to someone in the emergency medicine tier. Shout out to Laura T for being a patron. And thank you all for listening. We're your hosts, Will and Kristin Flannery, also known as the Glaucomfleckens. Executive producers are Will Flannery, Kristin Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Editor, engineers, Jason Portillo. Our music is by Omer Benzvi. To learn about Knock Knock Hi's program disclaimer, ethics policy, submission verification, and licensing terms, and HIPAA release terms, go to Glaucomflecken.com or reach out to us, knockknockhigh@human-content.com with any questions, concerns, or fun medical puns. Knock Knock High is a human content production.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.